Hello, everyone. Thank you so much for joining us. We have an exciting event here tonight. Really excited to have you joining us. My name is Ashley. I'm the coordination advisor for cancer prevention at the Central Regional Cancer Program. I'm really excited to welcome you all to tonight's session. So we are excited to have you for smoking cessation for primary care. A few housekeeping notes I just wanted to touch base about. So the session today is being recorded. Your camera and your microphone are off. For today's session, the chat box is not available, but we do encourage you to use the Q&A function to ask questions throughout the session. Our moderators will be monitoring this Q&A box for questions and comments that are directed to the presenters. We will do all of our questions at the end of the presentation. If you're having any issues or any questions with logging in, please contact Stephanie at our email listed here, icsregional@southlakeregional.org. There will be an evaluation survey that's sent out after the webinar. Please do take the time to complete that survey. And you will receive your letter of accreditation at the email you registered with to claim your credits, as well as the link for the recording to the webinar within 1 week of the session. And I just want to take a moment to do a land acknowledgement. So the Central Regional Cancer Program, located at South Lake Regional Health Center, recognizes and acknowledges the lands originally used and occupied by the First Peoples of the Williams Treaties First Nations and other Indigenous peoples. On behalf of the Central Regional Cancer Program, we'd like to thank them for sharing this land. We would also like to acknowledge the Chippewas of Georgina Island First Nation as our closest First Nation community and recognize the unique relationship the Chippewas have with the lands and waters of this territory. They are the water protectors and the environmental stewards of these lands, and we join them in these responsibilities. And just a reminder, this 1 credit per hour group learning program does meet the certification criteria for the College of Family Physicians of Canada. It has been certified by continuing professional development, so you will be able to receive up to 1.0 main POC credits. So without further ado, I'd like to take a moment to introduce our speaker for today. It's Dr. Bill Evans. I'm just going to take a moment to stop sharing my screen so that he can load up his slides for us all. And while he's doing that, I'll just let everybody in on the wonderful, wonderful Mr. Dr. Bill Evans. So Dr. Bill Evans, please feel free to go ahead and share your screen. Dr. Evans is a Canadian medical oncologist whose combined clinical practice focused on lung cancer with various administrative roles over his career, including executive leadership of cancer centers in Ottawa and Hamilton, and as the Chief Medical Officer at Cancer Care Ontario. Dr. Evans is now Professor Emeritus at the Department of Oncology, McMaster University, and the Clinical Advisor on Smoking Cessation at Ontario Health Cancer Care Ontario. He chairs the Tobacco Control and Smoking Cessation Committee for the International Association for the Study of Lung Cancer. He has published over 300 papers in peer-reviewed journals on various aspects of lung cancer treatment, smoking cessation, and the cost and cost-effectiveness of cancer care. So please join me in welcoming Dr. Evans for today's session. Thank you so much for being here. And just give us a moment here. It looks like we may have had Dr. Evans kicked out of the meeting here. So just hold on, bear with us for a moment here. Apologies for the delay, everyone. Thanks for sticking with us here while we just work out a couple of technical difficulties. Hi, Dr. Evans.
Hello there. I don't know what happened, but one computer just sort of died on me, and so I've switched to another laptop, and I managed to get back in. So I don't know where you are in the whole thing. I suppose everybody's waiting for me to say something profound.
No problem at all. We've just finished introducing you, so if you'd like to take a moment to share your screen there, and we'll be welcome for you to get started.
All righty. There we go. This is working.
Perfect.
All right. I apologize to everybody for that little technical glitch, but you can't go on Teams without somebody having a problem. This happens to be the presenter tonight. And thank you all for joining to hear this presentation about smoking cessation and cancer. I know primary care providers are extremely busy these days and probably have had an exhausting day. So I hope you find what I'm going to talk about of interest and of value to your practices. In discussion with Dr. Alan Kaplan, we came up with 3 objectives for today's presentation. One was to increase your understanding of the impact of tobacco use on cancer patients and why smoking cessation is important for cancer patients. The second is to give you some understanding of the potential harms and health impacts of e-cigarettes and their use as a smoking cessation aid. And thirdly, identify appropriate smoking cessation treatment plans for your patients and make you aware of some of the community support programs that exist in your area. I have no disclosures to make for this presentation. I always like to start with this slide. It's kind of a reminder that smoking is a pleasurable experience. Those of us in the healthcare profession sometimes say, oh, I can't understand why people smoke and it's a dirty habit and so on and so forth. But in fact, it's pleasurable. And within about 10 seconds of inhaling smoke from a cigarette, you get very quick absorption in the brain, in particular areas called the reward centers, where there's a release of dopamine, and that's what makes it pleasant and causes patients to want to have, or individuals to have that experience over and over again. And I think we're all familiar with some of the factors leading to tobacco addiction. Typically, if parents have smoked, you've been around smoking, you're more likely to smoke. The friends you keep have an impact, and certainly when you're growing up, there may be a group that you want to be part of, and some of them may smoke, and that may draw you in. And then there's some personality traits, particularly in young men who are more risk-taking and cessation-seeking behaviors. So all those things may help to initiate smoking. But as well, adverse childhood experiences growing up may lead to one being an adult smoker. It's interesting to note, too, there's some genetic factors. We tend to forget about that, but the age of onset of smoking, the number of cigarettes you smoke in a day, bears some relationship to certain genetic variants. And even the effectiveness of smoking cessation is determined by some of these genetic variants. Well, it'd be not so bad if cigarette smoke didn't contain 7,000 different constituents, many of them known to be harmful, like hydrogen cyanide, carbon monoxide. And there are about 70 carcinogens, including things like arsenic and nitrosamines and polycyclic aromatic hydrocarbons. And so decades of smoking lead to illness and a marked increase in the risk of lung cancer, particularly those who are heavy smokers, marked increase in coronary heart disease. But the good news is the bottom line on the slide, which is that we can help patients to quit smoking before age of 40. The risk of death from a tobacco-related illness is reduced by approximately 90%. It's pretty dramatic. So you're at the front lines of seeing people in your practices, and just keep that in mind, that if you can help people at a young age to stop, you're really helping to reduce their risk of dying from one of the many tobacco-related diseases. The problem for people who start is that it's very hard to quit. The withdrawal symptoms that you get tend to be quite strong and peak within a couple of days after you stop smoking. They gradually diminish over a week, but they can persist and lead for a long time. And sort of the memory of the pleasurable experiences may be enough to draw one back in. Now, most relapses occur in the first week or so after quitting. And because of those cravings that occur, the lack of the positive reinforcement, only a few percentage of smokers are actually successful in remaining abstinent for a protracted period of time if they try and quit on their own. So we know that quitting is very difficult, hard to permanently quit. Used to say that with 6 or so quit attempts before you stopped. I think the literature now suggests it's a great deal longer, or more quit attempts are necessary. And hence, a very practical point for primary care is that ongoing follow-up is important with patients after a quit attempt to keep encouraging them to maintain a tobacco-free situation. So it's not a one and done. It's many attempts before permanent abstinence and ongoing encouragement, empathy, and support. So why should we be particularly concerned about cancer patients quitting smoking? Well, with evidence-based best practices, up to 30% of patients have long-term abstinence. And in others, we can reduce their tobacco consumption. And I'll show you why that's important shortly. It's really about the fact that quitting after a diagnosis of cancer improves clinical outcomes of treatment. And I'll show you a bunch of slides to underscore that fact. And it's interesting that survival rates are improving in cancer, and some of the treatments, in fact, have made a dramatic difference, particularly the use of immunotherapy in melanoma is one example, but you can point to many examples in oncology of patients who are having long-term survival now. So if the patient continues to smoke after a diagnosis of cancer, they're placing themselves at increased risk of a second primary and all the non-oncology related tobacco illnesses. So this is an important reason why it's ever more important now to help the cancer patients stop smoking. And if they do stop smoking, it really increases the efficacy of the treatments that we're using and also their safety. It increases their survival time in years and improves their quality of life. And it decreases the treatment-related toxicity, the risk of a second primary, and of the cancer recurrence. And from the U.S. Department of Health Services Surgeon General's report in 2014, the Surgeon General estimated that quitting smoking at the time of a cancer diagnosis may reduce the risk of dying by 30 to 40%. So not small. And cessation makes a difference to all of the modalities that we use in cancer. So for surgery, the 30-day mortality rate after any surgery, cancer surgery, but could be orthopedic surgery and so on, is higher among those who smoke, and returns to the operating room are more frequent. People who smoke have more complications from general anesthetics, more likelihood of having lung infections, and there can be delay in the wound's healing and infections of the surgical wound because the nicotine leads to vasoconstriction, hence less blood flow into the wound, and impairs the inflammatory response, the neutrophil migration into the wound, so the risk of infections increased, and it impairs fibroblast activity and the deposition of collagen, making for a weaker wound and a greater likelihood of wound dehiscence and even late hernias. With regard to radiation therapy, we know that radiation works best when the blood oxygen level is normal, and smoking reduces the tissue oxygen levels. And in studies, it's been shown to reduce the rate of complete response to radiation treatment and to decrease overall survival and progression-free survival. There's quite a dramatic example from a Canadian trial that was led by Dr. George Broman when he was head of the Cancer Center in Hamilton. So there's a study done in radiating patients with head and neck cancer. And from the slide, you see the complete response rate for those who continue to smoke was 45% versus 74% for the non-smokers. And look at the remarkable difference in the 2-year survival between those who smoke, 39%, and 66% 2-year survival for the non-smokers. And on this slide, you see the survival on the left-hand panel of those who did not smoke versus those who smoked, and the dramatic drop-off of those who continued to smoke. On the right-hand panel, note that there's an intermediate survival curve. These are the people who were smoking up until the time they started the radiation treatment and then were encouraged to quit. And you see how their survival, although not as good as the people who hadn't smoked in a long time, is much better than those who continued to smoke. With regard to the systemic therapy agents we use today, I wish we had a lot more information, but on the slide you see 6 drugs that we use. Some of them are what we call molecular targeted therapies. The first 2 are those, and then the others are all types of chemotherapy. Most of these agents are metabolized in the liver, and when you inhale tobacco smoke, the polycyclic aromatic hydrocarbons induce some of these liver enzymes that you see in the second column. And by inducing them, they remove these drugs from the circulation out of the body more quickly. And as a consequence, there are less side effects, but there's also less effect on the tumor. And we've seen in relation to lung cancer patients, those who've been prescribed erlotinib for their lung cancer because they have an EGFR mutation, have a much lower response rate. And it would appear that from studies that you'd have to give twice the usual dose to have the same effect and get the same response rate. Of course, we don't usually do that in practice. And sunitinib, which is a drug used to treat metastatic kidney cancer, evidence shows much shorter survival. And some of the other drugs, we see less evidence of myelosuppression, and by inference, we believe that it's having less impact on the cancer. That just makes sense. So apart from the tobacco smoke inducing the liver enzymes that clear the drugs, it can also induce what we call acute phase reactants in the bloodstream. And some of these acute phase reactants bind to other chemotherapy drugs, particularly those in the taxane class. So you may have heard of Taxol and docetaxel, commonly used in the treatment of breast cancer and prostate cancer when it's metastatic. And again, this makes these agents potentially less effective. So the growing awareness that smoking could have an impact on a cancer diagnosis has led to more and more publications. And with the publications, now meta-analyses are being done. And on this slide, you see meta-analyses for lung cancer and head and neck cancer. For lung cancer, now 21 articles or more now about the impact of continued smoking after a lung cancer diagnosis. In the 21 articles with over 10,000 patients, quitting smoking at or around the diagnosis led to a 30% lower risk of death. In head and neck cancer, smaller number of studies, 2,300 patients though, a 20% lower risk of death. So significant impacts. In GI malignancies, not quite as much evidence at the moment. Number of studies in colorectal cancer, only single studies in gastric and liver, but suggestive that if you quit, you live longer. Bladder cancer studies are conflicting at the moment, so we have to wait for more results, I guess. I mentioned kidney cancer earlier and the effects of sunitinib and interacting with cigarette smoke. This is an interesting study just recently published. Comes from Russia, from the Cancer Research Center there in Moscow. 212 kidney cancers, and 40% of those individuals who were smoking quit at the time of diagnosis. And with long follow-up here, you see a remarkable impact of quitting versus continued smoking. Really a 50% decreased risk of death overall, and almost the same decrease in the risk of cancer death, and remarkable decreased risk for disease progression. And it's well shown in the graph on the right-hand side of the slide. And this is another recently published meta-analysis on hormone-dependent cancers. We don't tend to think of breast cancer and ovarian cancer, endometrial cancer, or prostate cancer and tobacco smoking. There's not sort of a causal effect there. So we haven't really thought about it, how cigarette smoking might impact treatment of these various cancers. But here's a recent meta-analysis of all of these studies. And in at least 3 of them, breast, ovarian, endometrial, smoking cessation led to better overall survival, better disease-specific survival, and disease-free survival compared to continued smoking. Interestingly, no evidence of an association between continued smoking and survival for prostate cancer. So the bottom line really is, if a cancer patient's well enough to be treated with surgery or radiation or any type of systemic therapy, then the evidence really indicates that they'll have a better outcome if they can be helped to stop. And in fact, cancer patients typically want to have a discussion about smoking. This is interesting data for Princess Margaret Hospital collected by Lawson Inc., showing that over 3/4 of patients felt they should have that discussion at the first visit. And almost 90% felt that discussion should be with an oncologist rather than other members of the healthcare team, which is interesting because it's frequently the nurses and sometimes others, not the oncologists, who have those conversations. The oncologists focusing more on the technical aspects of the delivery of the cancer care. So it's kind of a wake-up call for oncologists that they should be having these conversations with their patients. And this is some more data from Princess Margaret, just showing the readiness of cancer patients to quit smoking. Lung cancer patients and head and neck cancer patients tend to be the most heavily addicted to tobacco. And yet 60% of these new lung cancer patients were very interested in making a quit attempt in the next month. Another 18% somewhat interested. And the proportion of head and neck cancer patients who are currently smoking, who are interested in quitting, is almost 90%. So patients are receptive, cancer patients are receptive. They're expecting their doctors to talk to them about smoking and smoking cessation. And so we need to have a smoking cessation treatment plan for them. And guidelines based on a lot of research make a number of key recommendations about managing patients with tobacco addiction. First of all, they all should be advised to stop smoking as soon as possible. And it's really a combination of medications and counseling that's going to make the difference. And there's a number of evidence-based approved medications we'll speak of. And also the counseling can take many forms, and we'll just review those in a moment. But it can't be as modest as just brief advice about why one should quit. With regard to the evidence-based recommendations for medications, a prescription of a combination of the nicotine patch plus a short-acting nicotine replacement formulation, one of the 5 available, including lozenges and gum and spray and so on, or varenicline, or the combination of NRT and varenicline, or bupropion. I think more evidence is in support of varenicline than bupropion, but you have your choice of those agents. And if using varenicline, it should be for a protracted period of time, at least 26 weeks. If using bupropion, can be even longer for those who are at high risk for relapse. And those would be the people who have relapsed multiple times before or have a high heaviness of smoking index. At the bottom of the slide, it says patch, and we'll start there. One of the things that's important to recognize is that the strength of the patch you prescribe has to be sort of proportional to the number of cigarettes smoked. So if a patient smokes 10 or more cigarettes a day, you should be starting with a 21 milligram per day patch for approximately 6 weeks, and then try and reduce it 14 milligrams for a few weeks, and then 7 milligrams for several weeks, and then try stopping. And it may be necessary to bump it back up if the patient relapses. If patients have more than 10 cigarettes, and some are smoking, 20, 30 cigarettes a day, you could go to a 28 milligram per day patch, but you'd have to put a 21 milligram and a 7 milligram together, etc. So you have to adjust it to the number of cigarettes smoked. And as you can see, if you start patients who have 10 cigarettes per day or fewer, you probably would start at a 14 milligram per day patch and for the 6 weeks. Now, varenicline, which I think would be the preferred option, either alone or in combination with the patch and short-acting forms of nicotine replacement. And the standard dose will be a milligram per day, but starting with a half a milligram once a day, and then after 3 days, increasing to twice a day, and then the single milligram tablet. Some variability may be required, just depending on the individual patient, and the duration of treatment somewhere around 24 to 52 weeks. With regard to counseling and behavioral interventions, there's a variety of things. I mentioned a brief advice, which can be as simple as a minute or less, but at each encounter, really delivering a simple message about the potential benefits of smoking, the difficulties of smoking, the support that you could provide, the encouragement, and delivered in an empathetic way. I think that's really critical. I think many people who use tobacco feel stigmatized, and if the doctor or anyone just tells them you should stop smoking, it's bad for your health, it's really not that helpful. Doesn't feel very supportive, and we need to perhaps suppress our feelings towards smoking and regard the patient as an individual who has an addiction, and we wouldn't approach others with addictions in a non-empathetic way, I don't think. Counseling can be individual or in groups. It could just consist of providing advice about how to stop smoking and practical strategies on quitting, how to deal with the cravings. Sometimes it's the small little details that make a difference about how to use nicotine gum. Don't just chew on it continuously where you chew bubble gum. You chew on it till you feel the tingling in the mucosa, and then you put it between cheek and your teeth. Wait till the tingling decreases. That's the effects of the nicotine absorption. Then you chew it a little bit some more till the tingling returns, and then put it back in your cheek. And it's little things like that that can really help the patient be successful in their cessation efforts. But counseling may involve more cognitive therapy and overcoming some of the maladaptive thinking, the fact that I've tried 20 times before, doc, and I've always failed, and I need this as a crutch. This is my friend, my cigarette's my friend. And this may require a more sophisticated level of counseling. But those sessions need to be longer, obviously, to dig into what's causing the patient to smoke, what are the triggers, what the benefits are, how smoking cessation interventions can be helpful. So typically they're 15 to 30 minutes, but can be even longer, and really should go on over multiple weeks. I think they're best in person, frankly, but given today's world with COVID and other respiratory infections and so on, more of this may have to be done either by phone or by computer. And typically, it's a trained professional that does it. Now, there are other forms of ways of incenting patients to stop. Some of them are financial, or the Canadian Cancer Society has one where you have a chance to win a car. These things have variable effects, but can be short-lived when the incentive goes away. So if you're not continuing to provide some kind of financial incentive, the patient may go back to smoking, or you're going to become poor supporting them financially. And text messaging is increasingly being used particularly amongst youth, to kind of push out messages to individuals' mobile phones. It's very cost effective. You can have a large reach with it. And I think it's going to be used more and more, and particularly in the context of vaping. Now, there are quite a few community supports in Central Region that you could tap into for your patients. Smokers Helpline, run by the Canadian Cancer Society, is an online resource, and it doesn't cost anything. There's access to tools to help individuals quit and for information. And Talk Tobacco is also made available by the Canadian Cancer Society, another free and confidential program that provides culturally appropriate supports to our First Nations people, Inuit, Métis, and the urban Indigenous communities. And it also offers free NRT patch and gum. And there are pharmacies in Central Region that can be reached through the URL that's on the slide. Pharmacists, many of them have had training in smoking cessation techniques, and they could provide the pharmacotherapy necessary to support these patients. And then relatively new is the Ministry of Health's quit line, Health 811. It's really replaced the Canadian Cancer Society's quit line, and patients can either call or be referred to the smoking cessation program. You can fax a referral to Health 811, and some of the details of that are on this slide. You see the fax referral number, how to call them, and a quick coach can be assigned to an individual patient. There are free supplies of nicotine therapy available. There's health information that's relevant, and there are various ways that supports can be provided by text, chat, and so on. So those are some of the resources. And then there's also the STOP program, and STOP stands for Smoking Treatment for Ontario Patients. It's a program initially that was a research program at the Centre for Addiction and Mental Health in Toronto, but has now been evergreened and has funding from the Ministry of Health. It's province-wide and can deliver smoking cessation treatment, both free nicotine replacement for 26 weeks, as well as counseling support for patients who want to quit. And if you're in a family health team or a community health center, a nurse practitioner-led clinic, addiction agencies, you can partner with CAMH to implement. STOP is also available on the internet, so STOP on the net. And again, through this online program, patients can receive free nicotine replacement therapy, and in the form of patches or gum and lozenges, which will be mailed to their home address. And then there are a few other community supports from the Lung Health Foundation. There's an app from Quash, and a URL there for Smoke Free Curious, where you can access quit smoking tools and resources, and mental health tools as well. And a lot of this is available by getting in touch with South Lake Regional and provide hard copy smoking cessation materials to your office. They can also be accessed by emailing. So something else to take advantage of right in the Central Region. And I also want to alert you to the fact that there are two learning modules that Cancer Care Ontario has developed. One for smoking cessation for patients. It's an online learning module for people with cancer, and it helps them understand why quitting after a cancer diagnosis is important, and how to go about either quitting smoking or certainly quitting less. And the URL for access to that learning module, which is free, is at the bottom of the slide. And then there's also a learning module for providers. So this is meant to help provide all of you information about the benefits of smoking cessation for cancer patients, how to deliver smoking cessation interventions, and how to overcome some of the resistance to smoking cessation. Now, up until about September 30th, you could get credits through the College of Family Physicians. Right now, and until it's reaccredited, which will happen a little later in this year, the credits aren't available. But if anybody has done the learning module in the interval since I think September 30th and hasn't been able to access it, let Cancer Care Ontario know through Ashley, and we'll try and find a way to get you your credits for doing that learning module. Now, I want to have a couple of words only about the harms and health impacts of e-cigarettes and whether they're useful as a smoking cessation aid. First of all, with vaping, you don't have the products of combustion you have when you burn tobacco. So you're eliminating many of the toxins that come with tobacco smoke. However, there are still toxins, including carcinogens, that have been found in the vaping fluids and metals, amongst other things that are harmful. And so vaping isn't without toxic exposure and hence not without risk. And what we don't know is really what the risk is, cancer perspective or cardiovascular disease or any other long-term health effects from vaping. It just hasn't been around long enough, but you can be sure that there will be some effects of those who are heavy users and abuser of vaping products. And a particular concern is what's happening in youth. Twice the number of Canadian youth vape as smoke tobacco. So it's becoming the thing for youth. And the amount of nicotine in the vaping devices varies widely. And in some products, such as Juul, it's equivalent of smoking a whole package of cigarettes. And this is a real concern because of youth using these vaping products when their brain is still developing, and it may lead to long-term consequences and cognitive function. So there's real concerns about that. But as it relates to smoking cessation, there are not any vaping products that have been approved by Health Canada for that purpose. And I would say that in the field of smoking cessation, the use of vaping products as a smoking cessation aid is still controversial. In the UK, a randomized trial was conducted using vaping and counseling within a very structured program, and was found to be effective and as effective as the current best pharmacotherapy and counseling. So in the UK, vaping is accepted as an effective smoking cessation aid. Elsewhere, you would find that just casual vaping or trying to switch from smoking tobacco to vaping, not in a structured setting like a clinical trial, appears not to be that effective. And a concern is that vaping, for those who start vaping, is a transition to tobacco smoking, particularly for youth. So there's still some controversy there, but I think that overall, the risk of vaping in someone who's using tobacco extensively is less. And if they're really, really finding it difficult to quit using what is current best smoking cessation practices, then an attempt to quit using vaping is reasonable. And I was going to joke and say we should end on a high note and talk one slide about cannabis and cannabinoids and cancer risk, and whether there's any role for cannabinoids in management of cancer symptoms. So We've reviewed this at Cancer Care Ontario, and again, there's a URL at the bottom of the slide. But an extensive literature review shows no clear evidence that cannabis increases the risk of cancer. This again may be just because there hasn't been a long enough period of time pass for people who have used a lot of cannabis over their lifetime to actually develop cancer. So it may just be that the evidence will accumulate, but we haven't got it yet. Sometimes you hear patients say cannabis might be a treatment for cancer. I actually know someone who provides a cannabis type product up in the Muskoka area and claims to have cured cancer, but there's really no evidence that cannabis or cannabinoids can be used to treat cancer. And there's really no evidence to recommend either as an initial treatment for basically any health condition, including cancer-related symptoms. However, I'd say, and this was from our review with a number of experts involved, that adding a pharmaceutical cannabinoid when managing cancer-related symptoms that don't respond to standard therapy. So the cancer patient with extreme pain that's poorly managed with a combination of non-steroidal anti-inflammatories, analgesics, and opioids may be a reasonable thing to do. I know there are patients who find benefit from neuropathic pain, and certainly have had the experience of patients having improvement in nausea associated with chemotherapy who've used cannabis in advance of their chemotherapy treatments. But generally, we would not be recommending these as a first-line therapy, but only in the situation where the standard therapies have not responded. So I believe that's my last slide. So I thank you for listening to me and happy to try and answer your questions.
Thank you. Thank you so much, Dr. Evans. It's a fantastic presentation on smoking cessation to help us kick off Lung Cancer Awareness Month. Just a reminder for those that are in attendance, you can pop any questions that you might have into the Q&A box. So there's the button at the top of your screen if you'd like to enter any questions. I know Dr. Evans would be happy to answer any that you may have.
Or try.
Or try. We certainly do appreciate you being here to speak with our primary care teams, and for those who've joined us tonight to take some time out of their busy schedules. Just taking a look with our team here to see if we've got any questions coming in. I don't see any so far. I'll give it another minute here if you've got a question you'd like Dr. Evans to answer. And in the meantime, while we wait, I'd just like to remind everyone that, as Dr. Evans was mentioning, there's a lot of resources available. So you'll get some information from our team at the ICS regional email account with the survey link and the accreditation letters. So if you have any hard copy material requests, you can contact us there, and we'd be happy to connect you with some additional resources.
So with silence, maybe I'll ask myself a question that maybe some might be thinking. If patients are living longer, how is it stopping smoking with stopping smoking? What's the mechanism? And the short answer is don't really know, but it could be multifactorial. And one of the interesting aspects is that there's some basic science research that would show that nicotine acts on a lot of the signaling pathways in tumors that make the cells proliferate, that make them more invasive, that stimulate new blood formation, angiogenesis, so that the tumor can grow more readily. So it may be that that's part of the issue. I showed you that it's probably part of the reason the nicotine and more importantly, perhaps the polycyclic hydrocarbons are inducing these enzymes in the liver to clear drugs more rapidly. But then there's also the fact that if you continue to smoke, you have greater probability of smoking-related comorbidities, infections, and we're treating you with, say, drugs that lower your blood count. So multifactorial, a variety of reasons why stopping smoking at the time of a cancer diagnosis is important. And really, part of the value to me of having this conversation with you, working in primary care, to try and get your support for helping our cancer patients quit, and also to not perhaps undo the messaging we're trying to do in the cancer centers, because we have a whole program within cancer centers to screen new cancer patients, to advise them on the health benefits of smoking cessation, and to try and get them into smoking cessation programs, get them referred. And they get an overwhelming amount of information in cancer centers these days they have to process. And they may go back to you and say, well, they told me I should stop smoking. But if you hadn't heard this message, you might be inclined, if they had more advanced cancer, metastatic disease, you might be inclined to say, well, it's awfully hard to stop smoking. And I know you've been doing it a long time and it's something you enjoy. So don't worry about it. That's not the messaging we want you to deliver. We want you to be cognizant of the importance of supporting the patients in an empathetic way to help them quit, and that it will make a difference to the treatments that we're offering within the cancer center.
Thank you. Thank you for sharing that, Dr. Evans. We do see there's one question so far, a couple more coming in. So I'll just open that up. So one we have here, is a remote history of bulimia an absolute contraindication to the use of Zyban?
That's not a question I think I can answer as an expert. That's probably a Peter Selby question. Peter Selby being the head of the tobacco addiction service at CAMH. I honestly don't know, but maybe we can, if you can make note of who asked the question, either I can ask Peter or do some research on it and get back to you on that one. Sorry to let you down there.
Thank you. Another question here is, what treatment would you recommend for younger teenagers using vaping intermittently?
Good question. So here we're talking about something that isn't in the bag of tricks that an oncologist involved in smoking cessation has. The challenge here is that they're surrounded potentially by a peer group who are also vaping, very commonly in high school. So I think amongst the first things is to try and provide the advice and encouragement to be apart from the peer group. And that's going to involve some ongoing counseling. Secondly, we don't know how much nicotine is in most products. There's over 500 different vaping devices out there that people can access currently. And so the amount of nicotine is really hard to know, but taking a history on how often they're vaping can get some sense of how much they're using. And much as you would in dealing with an individual who's smoking, try to titrate back. It's kind of like a reverse nicotine patch in the reduction of the use of the vaping device. And you may, in the cases of those who are very heavily addicted, I think you're probably going to need to refer to professional counseling help to get their teenagers to get them off of the nicotine that they're getting through the vaping device. Again, this is an area outside of my expertise, so you're really stretching my knowledge. But I understand in primary care, you get all these questions. And so you you have a challenging life as a primary care provider.
Thank you very much, Dr. Evans. I do have another question here. Is there a benefit to cutting down on the amount smoked versus quitting? Some patients can't just quit.
I think that's a very good question, and that is more in my bailiwick. Thank you for the question. We really would like to see patients stop, but we definitely see it as success if they can cut back. And so if they can get down to the really essential cigarettes of the day, which may be the first one to get them going in the morning, that's definitely a benefit. And in relation to radiotherapy, you saw the slide where it spoke to the oxygen levels in the tissues being impacted by smoking. And we think that one strategy for those people who can't quit altogether, but may be able to cut back, is also to allow a window of time between the last cigarette and when the radiotherapy is actually administered. So they know the time they're going to receive it, 2 in the afternoon, they get stopped maybe 3 or 4 hours beforehand. That will have a less negative effect on the outcomes of the radiotherapy. As it relates to surgery, actually the studies really suggest that quitting at least 2 weeks before surgery altogether makes the most impact on reducing infections and negative impacts on wound healing. And I don't really have any evidence from the literature about timing or amounts as it relates to the systemic therapies we use. But kind of intuitively, it kind of makes sense that the more you can cut back, the less you're inducing enzymes in the liver to metabolize the drugs we're administering for cancer therapy. So cutting back in that context would be, again, beneficial. Thanks for the question.
Thank you. Just taking another look here to see if we've had any additional ones come in. I did receive a message that somebody was having some difficulty with the Q&A tab, so you can add a message to the chat if you're not able to access Q&A. Hopefully not too many people are having an issue there, but I don't see any other questions coming in at the moment. Just taking one last look at
there is a question about is it cysteine? How do I pronounce it? I'm forgetting how to pronounce it correctly. But this is really been used in Europe as a smoking cessation aid for quite a long period of time. It's very inexpensive, and it is approved by Health Canada, not as a drug, but as a natural product. And really, the chemical structure is very similar to varenicline. And there are trials going on in the US of a variation of this drug or this natural product. Of course, they're going to change it just a little bit to make it sound like a pharmaceutical so they can sell it and make money, but it is going to be coming along. And certainly it is available in Canada now and is legal. And it's been used for a long time in Europe because it's inexpensive and it appears to be as effective, certainly as NRT, and competes with varenicline. So that's a good question too.
Thank you. And would you mind, sorry, just remind us what medication that one was? I know you said it was a difficult one to pronounce, but
I'm having trouble if the spelling is correct on the screen or not. I think it may be wrong, but and so it's kind of screwing up my pronunciations tonight. But cysteine, I think. We'll have to check spelling.
Okay. No problem. Thank you so much for answering that one for us. And all right, one last look again here. I think that's the last one I've seen come through. So if we have any in the next minute or so while we're finishing up, we'll go over that. But I would just like to thank you again, Dr. Evans, once again for taking the time to share with us tonight. Really exciting to have you here and to be able to talk about this really important topic, especially as I said, as we're kicking off Lung Cancer Awareness Month, good timing. And for everyone who's joined us tonight, again, thank you so much for taking the time. We're excited that you decided to be with us tonight. So you will see an email from our team with the accreditation letter, the survey links, and the recordings for the webinar. And please feel free to send us a message if you have any further questions, and we'd be happy to get those answered for you. And no other questions I've seen come in. So thank you again, everyone, and I hope everybody has a wonderful night.
And thank you for your attendance. Good night.
Thank you.